And many times the questions that are being asked are being thought of by other people that are attending this. And I will even ask my own rhetorical questions as I move forward through this program. Okay, so again, top 10. We're going to move straight into it. I've got more than 50 slides of content for this presentation, so we want to move quickly so that we understand how those top 10 apply to your organization. The number one issue that we're facing, and it's the number one issue that we've seen for more than a decade when it comes to the HIPAA programs, when it comes to protected health information, when it comes to meaningful use, and now MIPS. We're seeing it in OCR audits. We're seeing it in the desk audits, the site audits. We're seeing it in the whistleblower actions, and that is the security risk analysis or assessment. It is a requirement. It's a requirement that it be done annually. It's a requirement that you are always ensuring that you're compliant with the newest administrative, physical, and technical safeguards. And again, it must be conducted annually. So what is it? Are we looking at just IT-specific information? It's about protected health information, but it's about the dispersal of that information under the security risk. And it not only applies to its security policies, it can be part of a privacy concern as well. You know, how does the patient check-in process work? Clean desk policies, calling out patient names within your facility. All of those things can be inherently part of a security risk assessment. So we know that security risk analysis is the number one failed issue with the organizations. In fact, it's failed in audits more than 67% of the times. And the security risk assessment is not just a one and done process. So we look at the total grants, we look at the security risk assessment not being sufficient or being performed at all. In fact, we had an organization here in Utah that just went through a corrective action plan working directly with the Office of the Inspector General. They were asked to perform a security risk assessment and still did not perform an adequate security risk assessment. Used just a checklist option that didn't include all of the necessary elements. So an initial SRA is going to obviously be your first and most difficult one. And it may not be your first SRA that's the most difficult. What I would say is it's your first thorough SRA that could be the most difficult, okay? Checklist options may identify areas to be considered, but may not take all of the necessary precautions into consideration. You know, at Healthcare Compliance Pros, our SRA looks at the organization as a whole, looks at your personnel, your onboarding, your termination process, how your HR works with onboarding your employees, assigning them roles within the security apparatus, access to the physical locations, access to your physical location by vendors and tradesmen and business associates, access to your PHI by your business associates. We don't even get into IT and electronic security until the final two sections of the security risk assessment process. Okay, so making sure that your SRA is complete is so important. And then once that SRA has been completed, it's about identifying deficiencies and developing a corrective action plan. Can you show that you are mitigating any findings or any deficiencies that are being addressed? Again, a compliant SRA is a living and breathing process of identifying risks, having a corrective action plan, reassessing, looking at what the updates to the program need to be on an annual basis, not just from the policy aspects, but also from, you know, IT infrastructure, encryption, what you're doing with hard copy PHI and destruction of that, access to your physical plant. And all of those things are changing all of the time. You're turning over employees all of the time. So how does that work within your security risk analysis process? Number one on the hit list for our top 10 items that you should be looking at in your organization. Number two goes in line with security risk assessment, but it is cybersecurity and social media. And the reason that we lump these two together is social media can introduce malware. Cybersecurity on phishing attacks can be directed at your individual employees. We can be looking at the blurring of personal activities and business activities performed on the same workstations. What are your potential organizational policies with regards to that? You know, have you tried phishing attacks? What are you doing with regards to malware? Do you have incident management? Are you training your employees on those necessary requirements? So with regards to blurring of activities, we've all seen it. You know, hey, I was looking at a purple mattress, and all of a sudden, all of the ads that I get on my computer are, hey, do you want to buy a mattress? Or, you know, again, social media posts. You're posting on social media about new puppies, and all of a sudden you're getting dog food advertising. So we know that there's a lot of that tracking that's happening. We have cookies, and we have trackers that are built into the system. You know, none of this stuff is for free. You know, people want to get all of those data analytics, and they're selling that information. So the more that you're blurring those activities, the more that you're sharing information out, even again in a personal and a private setting. Okay. When you look at the idea of this blurring, you know, employees don't see it as a problem. You know, your IT department talks about, you know, sending emails, or what are you doing with receiving personal emails at those specific workstations, okay? So again, this blurring of lines means that we're tracking information, we're sharing information continuously out for everybody within the internet. So phishing, have you launched a phishing attack? Have you tried testing your employees with regards to phishing? There are free phishing services out there that allow you to do single attacks to try and see if there's any kind of employee click-through rate within a phishing attacks. And we know that device phishing is up year over year since 2001. So the data collected by the sites, the apps visited on your mobile devices or on your personal workstations or on your employees' workstations mean that cybersecurity needs to be a focus for your organization, and those blurring of social media and cybersecurity requirements, okay? So in 2017, more than 158 million social security numbers and over 14 million credit card numbers were exposed. 27% of those thefts belonged to the healthcare industry. And when we talk back to the security risk assessment and the exposure that you have in maybe even monitoring your business associates, and they should be part of your security risk assessment process, we know that 27 or 67% of exposures of PHI happen at the business associate level. So it's what are you sharing with your upstream and downstream subcontractors, your billing companies, your subcontractors, your clearinghouses, or your DME companies? And are they taking that information seriously as well? Should be part of a security risk assessment for your organization. So increasing data collection, mobile devices, accessing health networks and health records, transmitting PHI. See this continuously within the physicians. We see pictures being transmitted across cellular networks. Okay, we just need to make sure that we're locking down cybersecurity and making it a focus. Now, social media is also joined with this idea of cybersecurity because we have 3.4 billion social media users worldwide. You know you have them there at work. Are they accessing that information on those workstations? Are they using even their mobile phones within that environment? Do those mobile phones have access to internal networks? Are you even allowing them to use internal networks, guest networks? What are you doing with regards to Wi-Fi security on those platforms? And again, social media allows those bad actors. You know, I get people asking or requesting contacts with me all the time. I don't know if those people are being secure within my friends, my family being secure within their environments as well. So we need to make sure that we have a social media policy for your organization about what is or isn't allowed with regards to posting. So healthcares must be educated. They must have a social media policy within the organization. Instruct employees not to post with caution, and never post picture stories or status updates of what goes on within the office, okay? Even if the patient says that they're okay with it, do you have a policy for a release of information or an authorization for release if you want to do social media postings? And again, use sound professional judgment for using social media for work-related purposes. Could be with regards to reputation management. You could have Facebook postings by your physicians for certain procedures that are done within your geographic region, within your community. They may have some kind of presence that they're trying to get out there to build out that practice. But again, make sure that you're using social media and not allowing that to be something that can break that PHI or patient-physician barrier, okay? Set expectations for how social media can be used and provide steps to take if there is a suspected breach or risk of compromise within the social media platform. I'm seeing information out there, or I'm getting requests. I'm starting to have patients reach out to me. What is your mitigation policy when it comes to social media within your platform? Okay. So, perform a security risk analysis. Security risk analysis should look specifically at your availability of social media platforms, phishing attacks, malware protections on your platforms, what you're doing with regards to your firewalling. Maybe you've got some kinds of proxy servers. Maybe you're using virtual private networking. That allows you to establish what your security protocols are and establish a risk management program. Identify and inventory your equipment there within your organization. And it's not just laptops. We're going to find out later that we have thumb drives, we have external hard drives, we have backups that are being used. What are you doing with regards to encryption or data recovery process, okay? Train your employees to better identify suspicious emails, messaging technologies. If you're an HCP client, we have cybersecurity awareness training that delves into that. Make sure that you're applying that to your employees and training on those cybersecurity requirements. And again, have an implemented social media policy. Okay, so number 2, cybersecurity, social media, they're conjoined, they support each other, and overall, we've got that security risk assessment process identifying those risks within your organization. Now, number 3, something that's just become a major issue here through 2019 and will be a major enforcement issue moving into 2020 is this right of access initiative. Now, something that changed, and again, I've been doing practice management consulting for more than 30 years, but something that's changed with HIPAA, and patients are starting to understand the ruling. You as practice administrators, you as medical professionals need to understand it as well, is the patient's medical record is the patient's. You know, I remember back when I would talk to, physicians that, hey, these are my medical records. These are my interactions with the patients. But the medical record under the HIPAA statutes has transformed into becoming the patient's medical records. You are the caretaker. You're the holder of record of that information for the patient, but it is their patient's medical record, and you have to understand that. You have to educate your physicians on that. And you have to educate your staff on what the requirements are for that release of information. So in 2019, the OCR initiated an investigative based on a complaint from a mother. The OCR found that the covered entity failed to provide the mother timely access to records about her unborn child. Okay. The covered entity did provide the individual with the requested information. However, it was more than 9 months after the initial request. Okay. And you're saying that this isn't going to happen in your specific practice. But are all of your employees educated on the right of access? Are they educated on how they can submit records requests and what records to release to the patient? You know, all the records that you're holding on behalf of the patient, if they're in your record set, theoretically, the patient can request all of those records, even if they were generated by another physician, because again, those records exist within your data set. Now they can get a more complete record. Maybe you didn't get all of the records from a physician, and you may notify the patient that not a complete record was transferred from the referring physician or from the previous physician, and they can move backwards in time and move on to other physicians to provide records requests. But again, they have the ability to access the entirety of the record set. Again, educating them on what records are available within the record sets that you're maintaining for them. Okay. So, second case, patient for allegedly, despite repeatedly asking a healthcare organization, failed to forward patient medical records to a third party. Okay. Now, this was an electronic format. So again, you have to determine what your cost justification is for providing records in a certain formatted type, and providing the patient with information about, if you're providing them in a certain format, what is the potential exposure using that format. In fact, to the point of even emailing records in an open forum if the patient authorizes it, and if you have the capability of doing so. Okay, so there's different methodologies for providing that information, but again, this was an electronic format. Failed to forward medical record, failed to provide them in electronic format, charged more than reasonably cost-based fees allowed under HIPAA. So individual states have costs that are established for them, but later we're going to show you how there's a federal mandate about a minimum charge, and we can also use state-based assessments. But as you see from the Office of Civil Rights, again, who is in charge of doing all HIPAA enforcement, healthcare providers have slow-walked their duty to provide patients with their medical records out of sleepy bureaucratic inertia. I would also say this, that failure to provide them with their information is also part of that. Well, these are my records. These aren't the patient's records. And if the patient wants access to them, they got to pay me for them. Okay. Do you know you can't even hold up their records if they've got a balance due? Okay. So you can charge them for producing the records, and you can charge them for a reasonable fee, but you can't hold their records against a balance due. So we hope to shift the imposition of corrective actions and settlements under the Right of Access Initiative will finally wake up healthcare providers to their obligations under the law. And again, that law was established with HIPAA, was established that the patient's records belong to the patients. So 5 tips to help you comply with the Right of Access Initiative, which is an enforcement action for the OCR in end of 2019 and now moving into 2020. Ensure individuals are provided medical records within 30 days of request, and faster if possible. Let's not hold up that records request process. Only charge a reasonable cost-based fee despite what your state law may be. For example, because electronic records, we are moving to policies such as the recommended flat fee of $6.50, no more than $10, depending on the complexity of fulfilling the request. So for example, if you have to produce it on some type of media, if there has to be information gathered out of a PAC system, a laboratory system to complete the medical records request, there may be more complexity involved. But again, this is not a money-making opportunity for the practice. You've got to actually show that the costs incurred were in line with the effort expended to generate those requests. Okay. Number 3, understand that the right to patient extends to parents who seek medical information about minor children. Okay. Now, the patient records request can come down. You may have to ask questions about non-custodial parent access to medical records, how to release that information, how to correctly identify who is part of that record set. But those are the questions you need to be prepared to ask, and need to be prepared to come to healthcare compliance pros to help you resolve if necessary. Okay. If you require individuals to request access in writing, make sure to inform individuals of this requirement. So don't just say, yes, we'll get those sent out, and then not process the request, because once it gets back to the records release, department within your organization or to the person who's in charge of doing medical records. They're not dealing with the correct forms. We can't get back a hold of the patient. So make sure that all of your employees understand your requests, your requirements for records release. Is there a specific identification requirement? Now you can put that into place. You can require the particular patient to come in and fill out a records request and provide identification to verify their identity. And you can establish those standards, but make sure that all of your employees understand those standards and that they can communicate them effectively to the patients. And do your research and ask questions if necessary if you are unsure about what records should be provided to the individual based on their records request. You know, some patients may come in and ask for their entire record set. They may be asking for information to be transferred about a specific scope of services to a referred physician, or they may be looking for follow-up on that, okay? Do not assume records should not be provided when they're requested, okay? So again, the entire record set would be the maximum that you could be providing, but make sure that, again, your employees, the release of information officer, the medical records department understands the questions to ask to identify what information should be released under that right of access initiative. So number 3, and something that we're seeing on enforcement actions right now, is right of access, okay? Number 4, exclusion screenings not being performed correctly or at all. So there's a number of different exclusion screening requirements. We've got the list of excluded individuals and entities. Now, are you just checking your employees? Are you just checking your physicians? Are you looking at your business associates, your subcontractors and vendors? Did you know that over 27% of the LEIE database is made up of entities? These are DME companies, these are laboratories, these are clearinghouses or medical supply companies, okay? Are you checking those? Are you checking the SAM list if you're participating in certain government programs? Are you, do you take TRICARE? So those individuals may show up on the SAM list, okay? So we just need to make sure that we're performing them correctly, and they need to be performed monthly. So where does this monthly come from? Now the advisement, the information, it doesn't specifically say monthly. What it does is says the list is updated monthly and should be checked as it's updated. So it's typical government speak. You have a monthly requirement because the list is updated monthly that you must check, okay? And if you're using any exclusion screening service, they should be able to perform that check for you on a monthly basis. And it's not a question of if, but when. We've already seen it within our own client bases. We've already seen it with clients who have come on with healthcare compliance pros, where they've seen exposure from an employee who is using a different name, maybe a maiden name prior. They have a vendor that was doing business in another state, and maybe they've moved states. Maybe we've seen a physician that's changed, okay? And this can halt federal payments immediately. You can have immediate payback ramifications. We have seen it, and this can truly shut a practice down. So we want to make sure that you're protected and making sure you're performing the exclusion screenings correctly, and that you can provide adequate documentation to an auditor if it comes in. And those audits can come in just in the form of a standard RAC or MAC audit. It can come in and say, look, we want you to provide us with information regarding your exclusion screenings, and you have to provide that. That's part of your contract, is providing information about your adherence to those CMS guidelines, okay? In 2019, we also saw the CMS preclusion list. Now, this isn't something you can even check against. The providers were notified specifically that they were part of the preclusion process and that they were precluded from participating in certain CMS programs. Medicare Advantage, they were Part Ds or prescribing for Part D. So there were certain preclusions that were identified, and again, they were notified that they were part of that preclusion list, okay? They were notified that they could appeal that preclusion exemption, but you should be asking your providers, maybe even asking for an indemnification letter from your providers, and we can provide you with a sample of that, saying, we're just verifying that you were not notified that you were part of a preclusion for participating in certain CMS programs. So again, that's just being forewarned, making sure that you're checking with your providers with regards to that preclusion list. And exclusion screenings are not hard. We just need to make sure that they're validated and populated with the information necessary for complete exclusion screenings. Making sure your business associate agreements are uploaded into the HCP system. Making sure that all of your vendors, all of your 1099s, your providers, all of your employees are entered into the system allows us to correctly perform the exclusion screenings as needed. Okay? Number 5, failing to have implemented auditing and monitoring. Now, when we talk about auditing, you might want to say, well, am I talking about billing and coding audits, documentation audits? Well, the OIG has a methodology for just the concept of auditing should exist. Now, auditing can exist in any process. Within the HIPAA security standard, auditing is the security risk assessment or analysis. Within the HIPAA privacy standard, it could be a facility walkthrough to making sure that privacy standards are addressed. Within OSHA, it's facility inspections. It's verifying, your fire extinguishers, checking your refrigerator temps. Those kinds of things can be an audit process within the OSHA program. Audit processing can be also following up and making sure your policies and procedures are updated. But it also includes monitoring your claims for accuracy, providing proper coding efficacy documentation for your providers, for your billers, and for your coders, okay? So we want to make sure that we're staying updated with not just compliance, but making sure that we're performing internal and external audits of your organization, billing and coding audits, documentation audits, and audits of systems for physical or security risks, which could be both the privacy and the security risk assessment process. Okay? Now, again, when I'm asked, what does auditing entail? Auditing entails monitoring and verifying information for any compliance process, billing and coding, HIPAA privacy, HIPAA security, security standards, or employee safety standards, patient safety standards. All of those can be part of an auditing process that you put in place, okay? We recommend both internal monitoring and auditing and a baseline audit that should be preferably performed by an external organization to educate your internal auditors of what the standards are, okay? And that ongoing auditing should be performed to maintain those levels of accuracy. I mentioned your physicians and billers and coders documentation and coding efficacy, okay? CMS recommends a 90% coding efficacy. Do you know that you're doing that within your documentation and follow-ups? You know that if you have coders that are checking other coders, how do you know that institutional variances or institutional education hasn't allowed information to slip to the point where you're not even sure about what you should be doing anymore, and that you got an institutional bias based on how you're currently doing and documenting coding? Hey, maybe you're billing 214s and you're checking your 99214s against each other and everything seems to be fine, but there's also an issue that should have been addressed with medical decision making or proper modification usage or other things. Number 6, mobile devices. Now, I talked earlier about social media. We talked earlier about cybersecurity, but mobile devices don't always just have to talk about laptops, don't always have to talk about phones. You'll see here in the case against the University of Texas Anderson Cancer Center, we have 2 lost USB drives and an unencrypted laptop. Now, it isn't just the information contained within the laptop. The USB drives by themselves contained, thousands of records of PHI. And even though they had identified a need for encryption, that they had failed to ensure that mobile electronic devices contained appropriate security measures, that they were locked up, that they were checked out correctly, that they had remote wiping capability, okay? You need to look at what your exposures are. And again, it doesn't just have to apply to those phones. It doesn't just have to apply to those laptops. What information is contained PHI, okay? Cell phones are used by your patients, your employees. Do you allow pictures within your facility? Do you know that there's pictures being taken within your facility? What other vulnerable areas do you have? And how can those policies, those failures to have policies, to failures to have written notifications, those failures for enforcement actions, if you notice that mobile devices are being used, recordings being used, the video recording is being taken, or photographs are being taken, how do you correct those actions? They're used by your medical providers. I know that some of the worst offenders are the physicians with using voice capture, text messaging, remote access, okay? And again, those USB drives make data storage and transfer effortless, but what are your policies for transporting those between different facilities? Are you using those for backup? Are you using those to transport information for off-site work, okay? There are risks associated with those mobile devices. And number 6 on the list for things that you should be looking at in your organization isn't just those cell phones, isn't just those laptops. It's any portable media that can contain PHI. Doesn't just have to be the thumb drive either. Have you got EKG machines? Have you got other pieces of even clinical equipment that potentially contain PHI? And how are you securing that information as well? Okay. So when we look at lack of security on mobile devices, there are 10 hit items that we should be looking at on our mobile devices for enforcement. Okay. Implement policies and procedures regarding the use of mobile devices in the workplace, especially when used to create, receive, maintain, or transmit PHI. Install or enable automatic lock and log off functionality. Require authentication to use or unlock mobile devices. Okay, they're using a thumbprint, they're using a face, are using a PIN code. Okay, regularly install security patches and updates, and if they're not willing to perform those functions, they shouldn't have access to PHI. They shouldn't have access to those systems, or they shouldn't be able to use those systems within your environments. Okay, establish encryption, antivirus, and remote wipe capabilities on any mobile device. Use only secure Wi-Fi connections. Use virtual private networking as needed. Okay. Prohibit downloading of certain third-party apps unless the apps have been approved. And securely delete all PHI stored on mobile devices before discarding or reusing the mobile device. Do a thorough wipe, do a thorough overwrite, okay? And again, train your employees on how to securely use mobile devices, not just on your policies, but on what the risks are that, again, can be part of the cybersecurity training that can be delivered to your employees, okay? Okay, number 7, missing mechanisms for employee and patient complaints. Now, the OIG has said for a compliance program to work, employees must be able to ask questions, report problems, okay? That's part of a communication protocol. It's part of the 7 pillars of an effective compliance program as established by the OIG, okay? You should have a process in place for effective and constructive communications, okay? Not just a suggestion box. Do you have an anonymous reporting process? Do you have a suggestion process? Do you have open door policies, or do you have mechanisms in place for complaints? Also, are patients advised on how to file complaints, who to file the complaint with? Have you updated that information? I've seen outdated notice of privacy practices that indicate phone numbers or email addresses or individuals who are no longer with the practice themselves. And that specifically can lead to a HIPAA violation and a disgruntled patient complaint. So we talked about the notice of privacy practice, how they can complain. Section 1557 of the Affordable Care Act talks about language discrimination. Okay, do you have an escalation policy for that? Do you know how to request and receive services and to file complaints with regards to that? Okay, now that is a requirement under the Section 1557 statutes as well. Okay, consider a hotline or suggestion boxes. Okay, you maintain the process, adopt the procedures necessary to protect the anonymity of the complainant. So that's a requirement under the whistleblower statute, that you have some mechanism for anonymous reporting. Okay, and again, it doesn't just have to be used for complaint purposes, it can also be used for other types of communications within your organization. Okay, so missing mechanisms for employee complaints. And again, don't forget that grievance procedure for Section 1557, okay? Includes investigating, it includes escalation, it includes how to file a grievance, who to file the grievance with. All of your employees should be notified of how they can request services or how they can escalate if those service requests are denied within your organization, okay? 8. And something that we're seeing, you know, it's funny, we have clients here at Healthcare Compliance Pros who all look at a subsection of their employee list, and I'll see that they're not regularly training, that they're not enforcing training within that particular employee subset. And I talk to other groups that are looking to onboard with Healthcare Compliance Pros, and they're like, well, I don't think we need to worry about training that particular subset of employees, okay? If you're ever subject to an audit, they're going to look at your entire employee roster. In fact, they may even pull your payroll records to make sure that all of that information matches up. So regular and effective education and training programs are number 8 on our hot list of things that you should be looking at in 2020. Okay, so if we're looking at that, what are the fundamental elements that should be included in training? Okay. Should be tailored to the healthcare organization's specific needs, specialty size, those kinds of things. Have you ever taken any trainings that ask you to look at a policy manual somewhere else, or to consult with a compliance office or anything else? Those aren't that isn't information that's tailored as part of the training process and doesn't deliver an adequate training experience. Who needs training? What type of training best suits the practice? And how often education is needed, and how much each individual person should receive. So training should be at time of hire, when there are updates, and there should be reviewed annually thereafter. We're talking about HIPAA, privacy and security. We're talking about OSHA. It is a required standard. You're talking about fraud, waste, and abuse, False Claims Act, the whistleblower statute, okay? Those are issues that are part of corporate compliance training, okay? And when we talk about that trainings, it is mandatory that they be trained annually, okay? OSHA, your requirements, your personal protective equipment program, your infection control program. We're going to be talking next week about specific infection control, patient communications, incident management, patient check-in and vetting processes that are all part of coronavirus. So those are all things that may be additional relevant training topics that come up. Harassment discrimination may be required specifically in your state. There may be opioid education training, especially for providers. Active shooter, CLIA training. There may be diversity training that may be a requirement. There may be follow-up trainings with regards to harassment complaints that are part of the disciplinary action or deficiency correction process. So make sure that you're developing a training program that actually meets the standards necessary for your organization. And if you have any questions about what trainings are required specifically for your group, you can always reach out to HCP, you can always reach out to your compliance advisor, and we can help you define that training program under our learning management system. Because all of that content is already there, it's already fully realized. We want to make sure that you're taking advantage of those training programs that are available for you. Okay. Number 9, and it's really interesting, suspected HIPAA incidents. Well, we've got breaches up here. It's HIPAA incidents, both privacy, both security. What is a reportable breach? Okay. And again, it's really interesting. I've been doing this for so many years. I'll walk into an organization and 50 employees. You know, we've never had a HIPAA incident. We've never reported a breach. We've never investigated a breach. We don't have any documentation on follow-up. Under the HIPAA omnibus rule that came out in 2013, it changed your relationships with your business associates, and everybody had to redo their business associate agreements to contain additional language. It changed the notice of privacy practices because you had to notify the patients about any marketing or their ability to opt out of marketing as part of that omnibus rule. But HIPAA omnibus changed another thing, which we're still trying to wrap our heads around. We're still trying to understand the enforcement actions. And that is that any HIPAA incident, both privacy and security incidents, must be treated as if a breach did occur unless you can prove the negative. So the requirement was that you look at any potential HIPAA incident as disclosing information. Can I prove that that information was disclosed? Can I prove that there was no harm to the patient? Can I prove that we've notified the patient, they've been educated, and we don't have a reportable breach? Those are all of your requirements under that, and you must document everything. Because what if it blows back on you 2 years later? The patient comes out and says, you know what, you told me that information wasn't disclosed. My identity's been stolen. I can trace that back to this incident. There's no other incident that potentially exposed my protected health information to give me this identity theft issue. Or you didn't disclose it to the patient at all, but it does come back that, hey, their identity was stolen. It happens to be somebody within your office. There was no breach determination process, no incident, no management, no education to the patient, no disciplinary action to the employee. Okay, those are all things where it comes back and blows back on the employee. Okay, so we have here St. Joseph Medical Center, schedules were missing, PHI of 836 individuals. Okay, now, however, due to a misunderstanding by the workforce member, the breach was not reported to HHS. Okay, well, you have a reporting requirement. You have a reporting requirement, even if the reporting is less than 500 individuals, you have a reporting requirement 60 days following the end of the year, which generally falls on February 28th, unless it's a leap year, but you know, that's your reporting requirement. But it's not just about the reporting requirement, it's also about the investigative action requirement, okay? A breach is an impermissible use or disclosure under the privacy rule that compromises the security or privacy of the protected information. Okay, I said it could be a security breach, it could be a privacy breach. But the reporting of the breach and the investigation of the breach is specifically under the privacy rule. Okay, is presumed to be a breach unless the healthcare organization demonstrates that there's a low probability that the PHI has been compromised. Okay, that was, again, that ruling that was part of the HIPAA Omnibus Rule 2013. Or is determined that an exception to the breach has applied. So what is an exception to the breach? Could the breach have affected TPO or treatment payment or operations? So in essence, a breach didn't exist because the exclusion rule applied for that information to be released. And that's, again, why we work so specifically with our clients on breach mitigation and follow-up, okay? So HIPAA incident management is worked specifically. We determine if notifications are necessary. You need to be doing that same process within your organization. And just because you report a breach on the HHS website does not necessarily mean that you are going to have any follow-up action from the Office of Civil Rights. In fact, the fact that you're reporting ultimately is going to show that you have a mechanism for incident management, investigation, and reporting if by any chance you ever have a reportable breach that results in an investigation. Okay? What's important is to make sure that you are following breach notification rule requirements without a reasonable delay. Okay? So if you experience a HIPAA breach affecting 500 or more individuals, you have a reporting responsibility no later than 60 days following discovery of the breach. Now that's important. It's 60 days following discovery of the breach. Much like your reporting requirements for overpayments are reporting for when you discovered the overpayment existed. And again, for 500 or less individuals, you have 60 days from the end of the calendar year, okay? And failing to do so is a serious compliance issues that can and could result in significant HIPAA fines and result in corrective action or your organization operating under a corporate integrity agreement, operating under additional oversight, okay? Number 10 on the list, compliance program deficiencies or findings not being communicated or corrected. We have a security risk assessment. We have a breach incident management process. We have a whistleblower complaint. We have a suggestion, okay? Are you communicating those risks as part of a compliance committee? Are you identifying and notifying your board? Do you have a mitigation process for those deficiencies to be corrected, okay? That's the corrective action plan. So we talked initially about the security risk assessment and developing a corrective action plan. And I don't care who you are, there's always going to be some kind of corrective process that you could do. How are your employees checking out equipment? How do they log in? Are you having employees sharing passwords or login process? Are you not properly shutting down your workstations as you leave an exam room? There's always a corrective action process and education that can be given to your employees. And that's part of a corrective action plan. If your security risk assessment process says you're good or you passed, well, that's not a sufficient security risk assessment process at all. And if you're using one or you've got a vendor that's doing that for you or saying that you passed your security risk assessment, you need to find somebody else because that's not the process. The process is to continual process improvement, okay? So a corrective action plan may be during a billing and coding audit, okay? Are you providing physician education and follow through? Did you just say, you know what, we billed so many 213s, they should have been billed as 214 or 212s. We have this much overbilling, you know, we'll take a look at that next month. Well, what are you doing? What's your corrective action? Is it part of dealing with your billers and coders? Is it dealing with the physicians? Do you have to adjust what your templating or encounter forms are doing as far as data collection? Is it part of how you need to deal with rooming the patients? Are you not collecting the correct information? Are you collecting the correct information up front as part of the check-in process? Okay, all of that is developing a corrective action plan. And corrective action plans can be ongoing. I've had organizations that have had, you know, hardware that they were going to be replacing over a period of years as budgets allowed. So it's not a matter if there being an immediate corrective action plan, but you must be implementing a corrective action plan and then following that through. We've also seen that with our own clients where they'll say, well, we're going to get that corrected, and then we follow up with them in mid-year, and yes, we do follow up with them, saying, have you had a chance to implement that new password policy? Or have you had a chance to implement that new log-off policy? Have you had a chance to talk to your physicians about that documentation issue? Or have you met with your practice management group about that new encounter form that you're going to start using or those new templating process that you're going to use, okay? That's how necessary improvements will be achieved, is by following up on that process. And that's something that our clients have us dealing with them at all, okay? Now, before I get on to questions, even though I haven't seen any questions populated into the system yet, I do want to again talk about the fact that we will be doing a special webinar next week on precautions for healthcare organizations dealing with patient interactions, dealing with patient communications, patient questions, dealing with your own staffing, PTO, sending employees home, remote work requirements, and if those are possible, all of those things will be part of our presentation next week on the coronavirus. And again, we will be talking about our new coronavirus toolkit, which will be all the education, handouts, reporting forms, policies, incident management checklists necessary for you as you're trying to meet. And it's always changing. So it's always going to be part of the CDC updates. We're probably going to move into a monthly webinar about making sure that new implementations are done. All of this stuff will be published out and available on our website as well. So I do want to mention that. Now, hey, we got about 5 minutes left here in our presentation. Any questions at all? I haven't seen any questions come through, but maybe I'm not on the right question tab, Nicole. Any questions that have come through at all?
No, not yet.
Okay. So questions that I get is my IT vendor's doing my security risk assessment. And they say I'm all good. Is that enough? Well, is your IT vendor looking at your termination policy? Are you removing access to the physical facility? Are you using PIN codes or keys? Do you use keys that can't be copied? And what is your process for changing out locks or changing out security codes? Okay, that's actual security of hard copy PHI that may exist within your physical facility. Are there multiple facilities to which they maybe have access to? Just a small thing. What is your onboarding process and training process? Is your security risk assessment looking at your onboarding process to make sure that your policies are updated and part of the training process that your employees receive? That's important, okay? When I talk about cybersecurity, you know, there are phishing attack sites that allow you to launch a phishing attack, so you can test one within your own facility. If you've got questions on that, you can reach out to HCP or you can reach out to your compliance advisor for suggestions on how you can launch those types of attacks. Okay. The exclusion checking. I've had groups talk to me about, you know, the Medicaid list at the state level. All of those lists roll up to the office to CMS over time. We can check those lists separately as well. And those are things that we can do within the exclusion checking. So I'm just trying to think of some questions that have come up as part of this process. Trainings, you know, HIPAA, OSHA, corporate compliance. I've got HR trainings. Do I have to do HR training every year? Well, did you change policies? How are you validating that that policy is getting out, or that you have a new PTO policy, or you have a new acceptance of any type of benefits? Now, you can do that through trainings, or using the HCP system. You can also send out documents, verifications for signature as well. So those are two different ways that you can deliver that as part of this program. Okay. All right. So we're just up to an hour. Wow. Out of 75 maximum that we got to on attendees, I still have 63 of you on. Again, don't hesitate to call me. Right there, that phone number, that rings directly to my desk. I don't even know why somebody put that in that slide, but that rings right at my desk. So you can call me, you can email me. Don't hesitate to reach out to me. And again, I do want to put in a plug for our special webinar next week, specifically for healthcare organizations and dealing with the coronavirus. Okay. You'll also be receiving an email about that will give you a link to how to sign up for that webinar for next week as well. Okay. So if I've not got any questions out there, and as my attendee numbers slowly go down as people see me winding up here, I'm going to say thank you for everybody who attended. Again, this meeting has been recorded, and the recording will be made available on our website as well. So again, thank you, and everybody have a great day.